Hello everyone, it's me again, Vladimir Polisico, a student nurse from Visayas State University. For today's video, we're going to talk about the infections of the urinary tract.
Urinary tract infection. It is an infection found within the urinary tract that is mainly caused by pathogenic microorganisms. It is considered as the second most common infection in the body and it occurs mostly in women. They are generally classified as infection involving the upper or lower urinary tract and further classified as uncomplicated or complicated depending on other patient-related conditions. Classifying urinary tract infections. Urinary tract infections are classified by location. The lower urinary tract, which includes the bladder and structures below the bladder, or the upper urinary tract, which includes the kidneys and ureters. They can also be classified as uncomplicated or complicated UTI.
Let's look at the pathophysiology. Here again is the kidney, the ureter, the bladder, the urethra. Here we have the inferior vena cava, and the renal vein comes from the kidney and enters the inferior vena cava. Behind the inferior vena cava, we have the descending aorta, which will supply the kidneys with the branching renal artery. So what initially happens, one, is contamination. Bacteria contaminates the lower urinary tract because of certain risk factors. Let's just say the bacteria is E. coli because it is the most common in 80% of cases. They initially colonize the urethra and the bladder. This triggers an inflammatory response in the lower urinary tract. Neutrophils are then recruited to this area. As you can see in the bladder, you have bacteria and you have neutrophils. The bacteria multiply and they are able to evade the immune system because of certain virulent factors. E. coli, for example, can bind to cells in the lower urinary tract and hide from immune cells. The bacteria can form biofilms. A biofilm is any group of microorganisms in which they stick to each other, and often these microorganisms adhere to surfaces and it allows them to survive. If this urinary tract infection progresses and left untreated, or if the patient is immunocompromised, has risk factors, the bacteria can ascend towards the kidneys and then colonize the kidneys, causing an upper urinary tract infection. And then from here, if left untreated, the bacteria can spread into circulation via the renal veins, causing worst case septic shock. A big risk factor for developing urinary tract infections, especially in females, is urinary catheterization. Same thing happens. The catheter can introduce infections straight into the bladder if not done hygienically. The bacteria colonizes the bladder, initiating an immune response. Neutrophils enter, further promoting inflammation. Fibrinogen accumulates on the catheter, providing an ideal environment for the attachment of uropathogens that express fibrinogen binding proteins. After these bacteria initial attachment to the fibrinogen-coated catheters, the bacteria can multiply and they can again form biofilms, promote epithelial damage, and can seed infection of the kidney. And so the same story occurs. In pregnancy, urinary tract infections are common. Catheterization will almost always result in a urinary tract infection. The reason being is not only is the urethra shorter in women, but during pregnancy, progesterone relaxes smooth muscle, causing stasis of urine, which allows for colonization, especially up to the kidneys. During pregnancy, it is important to perform urine analysis, because not only are urinary tract infections more common, but are also asymptomatic. Untreated urinary tract infections during pregnancy can have consequences for the growing infant in utero.
Risk factors of urinary tract infections. Contributing conditions such as female gender, diabetes, pregnancy, neurologic disorders, gout, altered state caused by incomplete emptying of the bladder and urinary stasis, decreased natural host defenses or immunosuppression, inability or failure to empty the bladder completely, inflammation or abrasion of the urethral mucosa, instrumentation of the urinary tract such as the catheterization and the cystoscopic procedures, obstructed urinary flow caused by congenital abnormalities, urethral strictures, contracture of the bladder neck, bladder tumors, calculi in the ureters or kidneys, and compression of the ureters. Factors that contribute to UTI in older adults: cognitive impairment, frequent use of antimicrobial agents, high incidence of multiple chronic medical conditions, immunocompromise, immobility and incomplete emptying of bladder, and obstructed flow of urine, such as urethral strictures, neoplasms, or a clogged indwelling catheter. Clinical manifestations may include burning on urination, urinary frequency, which is voiding more than every 3 hours, urgency, nocturia, incontinence, suprapubic or pelvic pain, hematuria, and back pain. Early symptoms of UTI in older adults may include burning, urgency, and fever. Some patients develop incontinence and delirium with the onset of the UTI. Assessment and diagnostic findings. Results of various tests such as bacterial colony counts, cellular studies, and urine cultures help confirm the diagnosis of urinary tract infection. The first one is the urine cultures. Urine cultures are useful for documenting a UTI and identifying the specific organism present. UTI is diagnosed by bacteria in the urine culture. The following groups of patients should have urine cultures obtained when bacteriuria is present: all children, all men, patients who have been recently hospitalized or who live in long-term facilities, patients who have undergone recent instrumentation of the urinary tract, patients with diabetes, patients with prolonged or persistent symptoms, patients with 3 or more UTIs in the previous years, and lastly, women who are postmenopausal, pregnant, sexually active, have new sexual partners, and with a history of compromised immune function or renal. Next is cellular studies. Microscopic hematuria is present in about half of patients with an acute UTI. Pyuria occurs in all patients with UTI. However, it is not specific for bacterial infection. It can also be seen with kidney stones, interstitial nephritis, and renal tuberculosis. Other studies: multiple test dipstick, leukocyte esterase test or nitrite testing, and tests for sexually transmitted infection. X-ray images, computed tomography scan, ultrasonography, and kidney scans are useful diagnostic tools. A CT scan may detect pyelonephritis or abscesses. Ultrasonography and kidney scans are extremely sensitive for detecting obstruction, abscesses, tumors, and cysts. Management of UTIs typically involves pharmacologic therapy and patient education. Various prescribed medication regimens are used to treat UTI. Acute pharmacologic therapy. The ideal medication for treatment of urinary tract infections is an antibacterial agent that eradicates bacteria from the urinary tract, with minimal effects on fecal and vaginal flora, thereby minimizing the incidence of vaginal yeast infections. Medications commonly used to treat UTIs: anti-infective, urinary tract bactericidal, cephalosporin, penicillin, trimethoprim sulfamethoxazole, urinary analgesic agent, fluoroquinolone. Long-term pharmacologic therapy. If infection recurs after completing antimicrobial therapy, another short course of full-dose antimicrobial therapy followed by a regular bedtime dose of an antimicrobial agent may be prescribed. If there is no recurrence, medication is taken every other night for 6 to 7 months. Long-term use of antimicrobial agents decreases the risk of reinfection and may be indicated in patients with recurrent infections. If recurrence is caused by persistent bacteria from preceding infections, the cause, if known, must be treated. After treatment and sterilization of the urine, low-dose prophylactic therapy each night at bedtime may be prescribed. Daily intake of cranberry juice can help prevent and control symptoms of UTI. Assessment. A history of pertinent signs and symptoms is obtained from the patient with a suspected UTI. The presence of pain, frequency, urgency, hesitancy, and changes in urine are assessed, documented, and reported. The patient's usual pattern of voiding is assessed to detect factors that may predispose him or her to UTI. Infrequent emptying of the bladder, the association of symptoms of UTI with sexual intercourse, contraceptive practices, and personal hygiene are also assessed. The patient's knowledge about prescribed antimicrobial medications and preventive health care measures is also assessed. And lastly, assess the urine for volume, color, concentration, cloudiness, and odor, all of which are altered by bacteria in the urinary tract. Nursing diagnosis may include acute pain related to infection within the urinary tract and deficient knowledge about factors predisposing the patient to infection and recurrence detection and prevention of recurrence and pharmacologic therapy. Nursing intervention in relieving the pain. Initiate antimicrobial therapy, antispasmodic agents, analgesic agents, and application of heat to the perineum. Encourage patient to drink liberal amounts of fluids. Avoid urinary tract irritants such as coffee, tea, citrus, and spices. Encourage frequent voiding every 2 to 3 hours to empty the bladder completely, because doing so can lower urine bacterial counts and reduce urinary stasis and prevent reinfection. Monitoring and managing potential complications. Patient must be educated to recognize early signs and symptoms, to test for bacteriuria, and to initiate treatment as prescribed. Appropriate antimicrobial therapy, liberal fluid intake, frequent voiding, and hygienic measures are commonly prescribed for managing UTIs. Patient is instructed to notify the primary provider if fatigue, nausea, vomiting, fever, or pruritus occurs. Periodic monitoring of renal function and evaluation for strictures, obstructions, or stones may be indicated for patients with recurrent UTIs. Indwelling catheter. Specific nursing interventions to prevent infection and urosepsis. Using strict aseptic technique during insertion of the smallest catheter possible. Securing the catheter to prevent movement. Frequently inspecting urine color, odor, and consistency. Performing meticulous daily perineal care with soap and water. Maintaining a closed system. And lastly, following the manufacturer's instructions when using the catheter port to obtain urine specimen. Upper urinary tract infections. What is pyelonephritis? Pyelonephritis is a bacterial infection of the renal pelvis, tubules, and interstitial tissue of one or both kidneys. Causes involve either the upward spread of bacteria from the bladder or spread from systemic sources reaching the kidney via the bloodstream. Pyelonephritis may be acute or chronic. Acute pyelonephritis usually leads to enlargement of the kidneys with interstitial infiltrations of inflammatory cells. Abscesses may be noted on or within the renal capsule and at the corticomedullary junction. Eventually, atrophy and destruction of tubules and the glomeruli may result. When pyelonephritis becomes chronic, the kidneys become scarred, contracted, and non-functioning. Chronic pyelonephritis is a cause of chronic disease that can result in the need for renal replacement therapies such as transplantation or dialysis. Clinical manifestations for acute pyelonephritis may include chills, fever, leukocytosis, bacteriuria, pyuria. The common findings are low back pain, flank pain, nausea and vomiting, headache, malaise, and painful urination. Clinical manifestations of chronic pyelonephritis may include fatigue, headache, poor appetite, polyuria, excessive thirst, and weight loss. Next are the medical management of acute and chronic pyelonephritis. Next is the nursing management for chronic pyelonephritis. When the patient requires hospitalization, fluid intake and output are carefully measured and recorded. The nurse assesses the patient's temperature every 4 hours and administers antipyretic and antibiotic agents as prescribed. Patient education focuses on prevention of further infection by consuming adequate fluids, emptying the bladder regularly, and performing recommended perineal hygiene. The importance of taking antimicrobial medications exactly as prescribed is stressed, as is the need for keeping follow-up appointments. Prognosis. The prognosis of urinary tract infection in women and men is excellent. With appropriate antimicrobial treatment and resolution of symptoms, there has to be long-term sequelae. that would be all for the urinary tract infections. Thank you for listening.